Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
We would like to demonstrate some important neurologic findings in a patient this afternoon. 51-year-old Miss Flynn, Dorothy Flynn, is with us, and she, when she was 31 years of age, started to have some symptoms that were rather important. You had some pain, Miss Flynn, did you?
Yes,
And where was that pain?
right here, the back of my head.
And did it spread from back there, or did it pretty much stay around there?
Very much in that area.
And what else was troubling you at that time? Did you have any difficulty getting around?
Yes, I did. Falling around, and I had trouble eating on this side.
You had difficulty eating?
On that side. That was before the operation, which I still do.
Yeah, difficulty in chewing, perhaps? Or?
Chewing, too.
And you had some trouble with your ear, too? Did you?
Yes, sir.
Was there?
It was just that once you're right about it, it buzzed.
There was buzzing in it.
Yeah. And then this started to bother me, my eye.
Yes.
It started to bother me before I was operated on.
And you had some dizzy spells and fell on occasion, is that right?
Yes, sir.
Well, we have then a patient who had some definite neurologic deficits, and the importance of these and emphasizing them is that trigeminal pain may actually be significant insofar as central nervous system disease is concerned, as well as the usual peripheral disturbances of neuritis and neuralgia that we see in common dental diseases. So I thought it was important for us to consider the problem that this lady had. She had pain in the side of her head and in an area that could be misconstrued for many things, such as temporomandibular joint disturbances and myofascial pain, a number of disorders. But I thought we should review a few things, and if we can return to Miss Flynn, we'll see that her right eye is closed. That has been closed since the operation some 20 years ago. It was closed intentionally to protect that area because of a number of disturbances in the cranial nerve regions and lack of reflex phenomena to protect the cornea. If we can put your head right back now, please, and we're going to review a few things about, and just turn right ahead. That's good.
Right there?
That's just fine. You will see an element of immediate asymmetry. The lines in Miss Flynn's face, the normal facial expression lines are here, and they're rather absent in a rather mask-like countenance on the right side. This would give us an index that the muscles of facial expression are not functioning normally, and we can review this by asking her to raise her eyebrows. Just lift your eyebrows up, and you can see that the normal forehead creases appear on this side, and she's completely flat over here. Now squeeze your eyes tight, and we see a much greater contraction on the involved side. A little bit of flicker here, but very weak indeed. And if we ask her to, now you can open your eyes, and just as her smile indicates, you again have a good demonstration. Would you pucker your lips up now? And you see, again, lack of any control or role in mentalis here, lots of activity on the opposite side, but relatively flat here. We would then go over a definite seventh nerve deficit, which seems to be complete on this involved right side. Now, among her symptoms are also those of numbness, sensory loss, and we would test for that. She indicates that she has had some numbness on this side, and we'll try with any sharp object, a pin or a sharp stick, will suffice as a criterion in stimulation. And she feels things sharp here, is it, Miss Flynn?
Mm-hmm.
And is there sharpness here, too?
I don't know what you're doing. I can't feel
You
it.
can't feel it, no. So, and about here, is it sharp here?
No.
How about this side?
Yes, sir.
Okay. And then down here,
Mm-hmm.
there's sharpness here. I'm sorry. And on this side, no sharpness.
No sharpness.
How about down here?
Yes.
Okay. Well, it's obvious we have cervical nerve innervation for sensory skin supply. Tell me when you lose the sharp sensation here.
Up a little farther. Right there.
Mm-hmm. You
I
can feel
can feel right here a little bit today.
a little bit there,
Uh-huh.
but not here.
No. Right there.
Now, we would then have an index that her sensory divisions, all three of them, ophthalmic, maxillary, and mandibular, are lost on this right side in a cranial nerve deficit. We would also remember that the fifth nerve has a motor root as well, and that motor nerve supplies the muscles of mastication. And we have, as a means to remember that there are 4 chewers, you recall, major movers of the mandible, which are the temporalis, the masseter, the medial pterygoid, and the lateral pterygoid, which move the jaws. Those are the 4 chewers. In addition to that, there are the 2 swallowing muscles, the mylohyoid and the anterior belly of the digastric. And also there are on this motor 5 2 tensor muscles, the tensor of the soft palate, tensor veli palatini, and the tensor of the middle ear, tensor tympani. So we would look for next evidences of motor deficit of the trigeminal. Would you open your mouth for us, please? And close, and open again, and close again. Now, there is not a significant deviation of the mandible to one side or the other. If there were a full motor deficit with no trigeminal action on this side, we would see a deviation of the mandible distinctly toward the involved side. As we ask the patient to bite down firmly, and she's capable of that, as we'll demonstrate in a moment, we actually feel the contraction of the masseter muscle on the right side. Bite again, and relax. Bite again, and relax. And I think you can see now bite again, my finger on this side being equally displaced laterally by the force of the masseter as it contracts. And up in the temporal region above the zygoma, bite now, and relax. Bite firmly, and relax. And that's pretty good. There's a little inequality, but as you'll see in a moment, that is due in part to her major dental losses. She doesn't have but a few teeth left, and so there's a good deal of imbalance there. So that is a rather important consideration in a neurologic evaluation, that she has a full ganglionic loss of all 3 divisions here of the 5th nerve on a sensory base, but she still has preserved the motor function on this side. We would then, she incidentally, insofar as other cranial nerves are concerned, we could test for olfactory sensation. One method to do this is to take some rather common aromatic substances and check on the patient's ability to smell them. We can ask them to close their eyes, and we can, in some way, try to isolate one side or the other. Have them breathe through the one nostril deeply, and ask them what they smell here. Take a deep breath. Is that a definite smell for you?
No.
Mm-hmm.
Yes.
Mm-hmm. What does that smell like?
Well, I like cloves.
Yes, that smells like cloves. Well, this is common in a dental office. This is oil of cloves, and it is something that can be recognized. And it's best then to switch substances, and we take a different material here, and we'll try a different side too. now if you'll take another deep breath through the nose. Is that an odor that you recognize at all?
That smells like nail polish remover.
Like nail polish remover, that's right. There is a solvent here in this. This happens to be compound tincture of benzoin, but it is reminiscent of the same thing. If there are 2 or 3, then vanilla or citrus orange oil or anything of that nature can be used as a test for olfactory considerations. When we then would turn from the first cranial nerve to the second, we have obviously a deficit here, but she has vision out of the left eye, and it's reasonably normal. We could ask her, would you look at the end of my finger? We could ask her to look at the end of the finger and move the globe up and down. These lights are bothering her a little bit, but now look at the end of my finger. Can you see it over here? That's good. Not too well. And look out here. Can you see it out there? She's having, just try to follow it. She has a little bit of 6th nerve deficit on this same side. Her lateral rectus muscle does not rotate the globe quite out, but most of the other ocular musculature seems to be intact, including the trochlear or 4th nerve. So we have 3rd and 4th nerve and 6th nerve to consider here, and we would check with light reflex and accommodation reflex pupillary reactions as we would view this. Looking next intraorally, we'd use a little bit of Vaseline to lubricate her mouth. Her lips are a little bit dry. In part, this is due to drying of secretions on the lips. Her abilities with this 7th nerve deficit, she can't control this right corner of her mouth, so that some of the salivary secretions tend to leak out a little bit here laterally, and she doesn't have many of the protective reflexes of the oral cavity. So we'll just take a look in the mouth and see some rather interesting changes that have occurred since this major deficit of cranial nerve functions has taken place. Try to open, Miss Flynn, widely. We would see partial edentulism immediately and a fair amount of gingival inflammatory reaction and the accumulation of some debris here. This occurs in part because of the lack of sensation on this side that we will demonstrate. We'll also see a great deal of heavy abrasion of the teeth and very sharp surfaces of these teeth. While we're in close, we'll have an opportunity to observe the lesion on the ventral surface of the tongue that has been observed and brought the patient in. Could you just keep open widely for a moment? As we look at, then, this ventral surface of the tongue, if I could have an applicator, please, we'd see an ulcer that is eroded, is quite deep, has a rather necrotic-looking surface. There's very little inflammatory reaction around it. You see it is not red, and obviously when I'm hitting it this way, it's any ulcer that you and I might have here would be excruciatingly painful, and we wouldn't be able to tolerate that. But she has this lesion in an area that is without innervation. I will palpate it right now, and it does not feel extremely firm. There's a little induration at the base, but the induration does not extend significantly beyond the confines of the clinical periphery. So we have a lesion here that is probably self-inflicted from these very, very sharp, abraded surfaces of her teeth. Would you stick your tongue out now? As she protrudes the tongue, there's a little bit of deviation toward the...
I'm sorry, doctor.
It's quite all right. Just stick your tongue out again. And then retract it, take it back. We'll recall the midline here, and we'll ask her again to stick it right out straight. And you'll see that there is some deviation toward the left. This would be suggestive, although with that, I guess it is adequate enough to suggest the possibility of some hypoglossal deficit. Can you move your tongue from one side to the other? Stick it out over here. That's good. Then stick it out over here. She has definite hypoglossal function on the right, but it is not, for one reason or another, this may be just lack of proprioception from the lingual nerve that produces this particular observation of the deviation. In a true 12th nerve deficit, the patient would deviate the tongue more to the right side on protrusion, to the left side on protrusion, and she'd be unable to deviate the tongue to the opposite side. So we would now check for the other branches of the peripheral trigeminal nerve that relate to the teeth by pulp testing the teeth, and with the standard electrical pulp testing, we'll get a baseline on the opposite side and use this just any kind of conducting paste here to place on the tooth. Now, Miss Flynn, if you'll open your mouth, and we're going to put this little thing on the tooth, and when you feel something, you raise your hand or give us a signal, will you?
Okay.
All right. Miss Yonkers here will help us with the pulp testing. Let's start now. And 4 and 6. Okay.
Oh, excuse me.
Well, I guess that's enough demonstration that there's vitality on this side. Now we'll do the same thing on this involved right side. Keep open widely. And we'll get good contact there. All right. And run that to 6, please. And 8. And 10. And 12. And 14. We might be able to demonstrate here. You see there's no response at all from pulps, and we'd expect that with the other evidences of complete third division trigeminal deficit. In the midline, we may be able to demonstrate some crossover. Try to close a little bit. That's just right. Now we'll see about this lateral incisor. Let's try it down again. You feel a little something there?
Uh-huh.
What is that at?
Oh, right there.
Mm-hmm. That's interesting that, of course, we do get some innervation that far forward. Let's try it again. Now we're at the central. That actually was hypersensitive, probably due to some of the abrasion that she's had there. What are we now? 4, 6, 8.
Oh.
Okay. So far as we come toward the midline, we've demonstrated certainly 3 vital teeth. Let's see about this one on the right side. As we cross over to the, maybe a little more paste here. We cross over to the opposite side. Let's check that now. Mm-hmm. 6, 8, 10, 12, 14.
Uh-huh.
You feel that a little? Well, that's reasonable demonstration. We had to go to maximal 14 to get any response from this adjacent central incisor. Shows a rather sharp, circumscribed division, but in local anesthesia in these areas, we have to accommodate for, by infiltrating across the midline, the decussation of that innervation. We would have observed the partial edentulum here and the degree to which she abrades these teeth. Can you try to get your teeth together? She has literally no occlusion, and yet I asked her when I observed the other day about these fingernails of hers and how she's able to get them in that condition. And she said that she could bite her nails. She's a little bit nervous and has been since her surgery. So I asked her, can you show us how you bite those? See if you can get that in there. Well, I have to tell you that from the side here, she's working on the nail, almost the height of the nail bed, against some of these razor-sharp, jagged edges of teeth. She's actually not biting them, but sort of tearing them on these razor edges that are there. And they're those razor edges that concern us, and we would like very much to bring across several ideas here, but one of them is that dental responsibilities are to remove those irritations in the oral cavity. After you relieve pain, the next thing you should do is eliminate the irritations, and particularly in a vulnerable mouth like this where there's no normal protective sensation on the right side of the mouth or face, these patients would need to have irritants eliminated. The interesting thing in the masticatory system here to demonstrate can be shown also radiographically. And we'll look at a Panorex view of Miss Flynn. The survey Panorex here is helpful in giving us a few of the correlated findings to the clinical examination just completed. We can see the gross abrasion of these teeth, the complete elimination of the cusps of these teeth. She's ground these down herself with habits of bruxism and has literally caused pulpal recession. There is a good deal of evidence of tremendous overloading of the masticatory system in this situation, and without, again, the normal proprioception from this same right side, because all of the input to the trigeminal nerve has been lost, and also because there is lack of proprioception throughout the masticatory system on this same side. There are a great many changes that have occurred in both temporomandibular joints. We can see in the temporomandibular joint here, even on the opposite side, a tremendous amount of deformation. Instead of having a normal convex surface in this head of the condyle, we see that it's extremely flattened, and it is expanded much as a mushroom as there's been this adaptation to the overloading of the masticatory system over these past 20 years while this patient has had her problem. Returning to our patient, we'll consider the fact that she had pain and some other signs of cranial nerve involvement 30 years ago when she had a life-saving operation by the neurosurgeons for what amounted to be an acoustic neuroma with extension into the brainstem area that we'll review in a moment. The important thing is that when you find pain that is unaccounted for by the usual forms of pathology, that you consider a careful appraisal of the other cranial nerve functions, and if you find patterns of deficit, if the seventh nerve is out partially, if there are other ocular signs or symptoms that may have a bearing on the possibility of a central nervous system lesion, it will be important for you to refer that patient to the neurologist so that that diagnosis can be made. Second thing that this patient exhibits is that in a very remote and often neglected area of the mouth, the floor of the mouth and the ventral surface of the tongue, she has a lesion, and that lesion could be significant in your role for cancer detection. It is a lesion that, if it does not heal after we've removed the irritation, will definitely be biopsied in monitoring and being sure that we are not neglecting a possible tongue cancer that could be, of course, another threat to her life.
Go ahead.
The other thing that we want to review is the elimination of irritation. And these sharp abraded tooth surfaces definitely should be eliminated. So we have demonstrated, could you put your head back once again, Ms. Flynn? We've demonstrated some of these neurologic deficits that added up to more than just a peripheral deficit. She is unable to hear on this side. We didn't demonstrate that, but any whisper or utilization of a watch, if you hold your watch up right over the external, do you hear anything there?
No.
And on the opposite side, you can often use this as a very gross estimate. Can you hear anything there?
Mm-hmm.
Okay. A cheap watch also helps to get the level. But we have then an eighth nerve deficit. She had some instability, so there was not only an auditory deficit, but also a vestibular deficit. She had imbalance. She had cochlear involvement from the buzzing or tinnitus that was there. There was pain on this side. She has a seventh nerve deficit. She has a fifth nerve sensory deficit. Motor is spared. She's able to smell. Her oculomotor, trochlear, abducens nerves are all intact. And so we would have some indication of this central nervous system problem. To review for just a moment the brain stem and some of the cranial nerve roots that are on that brain stem, we would, perhaps if you could just put your hand down there, that's good. We see here a little model of the brain stem, and you recognize the general areas. This certainly is the pons and the medulla here. And in colors, we see the origin or the roots of the several cranial nerves. The second cranial nerve or optic nerve has its chiasm here. The olfactory bulbs are not shown. So we have the second nerve. The third nerve is here at the superior portion of this crevice. The fourth nerve or trochlear is this little one that is coming around the corner here. The large fifth nerve root is shown here in orange, and it has this as its base, and the motor component of it is this darker blue, that's fine, the darker blue that runs along this portion of the root. This will go forward, of course, to the area of the Gasserian ganglion. Coming down to the junction, then, of the pons and the medulla, we have the location of so-called Pontine tumors and nerve roots that are commonly affected. We would have the sixth or abducens nerve here. You recall that's a very specialized one, just like the fourth, going just to one of the muscles that rotates the globe of the eye, in this instance the lateral rectus. And when that's knocked out, the eye will not be able to be deviated laterally. We found here in Miss Flynn that really there seemed to be a little involvement of the other abducens, and you can see that that's the closest one to the midline. The seventh nerve root is shown here in green, and you can see the close proximity of the seventh nerve and the eighth nerve and intermediate nerve, and why, if there is a central lesion in this location, one commonly finds neurologic deficits from these two roots. So we would have 7, 8. The ninth, or glossopharyngeal nerve root, is down here. We did not go through tests for that as it relates to sensation in the posterior third of the tongue, but we could have done that and would have, I'm sure, found the same sort of deficit that was present in the fifth and seventh nerves would also have been correlated to the ninth in this lesion. The lesion was an acoustic neuroma, and it did have an origin along this general area. And we'll review that again in a moment. Below the ninth is again the 10th. You recall the big vagus that has so many body functions comes off at this point, and the little 11th or spinal accessory nerve is here. The 12th or hypoglossal picks up the roots here from these little purple rootlets. So we have, in general, a location for a lesion that, if we recall in Miss Flynn, our patient, involved the fifth nerve sensory, not the motor, so it would have been a lower involvement here in the destruction of lesion and the effort surgically to get rid of it. The involvement of the seventh nerve, which is complete, the involvement of the eighth nerve. She has no hearing. She has had to adjust greatly through tremendous rehabilitation to the vestibular loss in her locomotion and gait that are involved. And the sixth nerve is certainly out on the same side, and a little bit of weakness on this opposite side. And so we would have probably a location in general for the destruction in this vicinity. An area then of lesion and a number of neurologic neoplasms will affect the area of the pons, and when they do, they demonstrate these patterns of cranial nerve deficits that we've tried to review for you with this patient. And once again, we would like to thank Ms. Flynn very much for giving us an opportunity to review this situation, which she has handled so very, very well through long years of great struggle for rehabilitation and coming around. She really gets along exceedingly well, and we are now in a position, we hope, to help her out a little for her mouth problems. This line drawing, loaned to us from the neurosurgery department, illustrates the bed from which the acoustic neuroma has been removed. The cerebellum has been retracted to the left from the brainstem, and we see on the right the segment of the eighth nerve. The acoustic neuroma is a supporting tissue tumor of nerve sheath which has been removed from the area of the eighth nerve. In the immediate proximity, we see the seventh nerve and how simply it is to inflict damage there, and often the seventh nerve is bound into the acoustic neuroma. And farther forward, we see the root of the fifth nerve, which also may be involved, the sixth nerve on the same side, the abducens is also closely involved. And these, of course, are the nerves that were afflicted in the surgical field in the removal of the tumor for our patient. Other cranial nerves of similar significance are, and if not more significant ones, are of course the vagus, the 10th nerve. We can see 9, 10, and 11 a little farther inferior on the brainstem. But this artist conception shows us well the field for the acoustic neuroma and why the cranial nerve deficits were inflicted when this tumor was excised by the neurosurgeons.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.